Okay, all right. And so this is what we had covered up to the advances. I had shown the slide of the uh, uh, amazing CT scan report, and then we had talked a little bit about asthma. So in just about a couple of minutes, I'll go through some of the other ones that we had missed. Okay, and yeah, this is where we had ended. So on part 3, for those of you who haven't had the time, this is what we had covered. Okay, which was sent out as a separate YouTube recording and Zoom recording. Okay, so I'll go through that. Okay, and how overly sensitive X-rays are, so we may be overdiagnosing. And then the radiation is nothing to be sneezed at by any chance. I'll just go through these 40 slides, very quickly as a refresher. And then with almost overly obsessive cleaning, asthma is increasing because we are not exposed to microbes. Okay, and a lot of people have said, that the association that killing all the microbes is in your body is not exactly beneficial, especially for vaginal deliveries, because so a lot of people are doing experiment that if you have cesarean section, to give the vaginal flora to the newborn to start building up immunity. So that's a research that is being done very carefully, so not to give infection. So there are some very interesting advances. And then in terms of dialysis, which was started, back during the war, and with, by a Dutch physician with geriatric equipment, basically, and that has spread all over. And with the coverage that was started by the Medicare for universal coverage, we have started abusing dialysis dramatically. And some of the nephrologists have game the system by trying to learn vascular access technology. And and it's not very profitable, so the hospitals have farmed it out to commercial outfits. So again, we have the good and bad that I'm trying to contrast, type of thing. So, and overuse. And I had nephrology friends who were lamenting as well. See, somebody who is 92, who is blind, has amputation, and I have to subject them to dialysis, and because of family pressure. And we had talked a little bit about the genetic advances. I think several of you were in the genetic class, and the biggest discovery of this year was the Watson and Crick things, and then the genetics has advanced, type of thing. And this was the timeline for genetics that I talked about, which I think, starting from DNA to various enzymes and chemicals to the rise of and again, we saw that good and bad go together with the saga of Elizabeth Holmes, who was totally a fraud company, and which raised like almost $800 million for totally fake testing. This was done. But again, there may be a real thing that may be coming through Stanford, that with one blood, they could do a total genomic analysis of DNA, RNA, proteins. So there are some exciting things that are coming on. And so we are awash in the form of data type of thing. So it's like our reductionism is paying off handsomely, so to speak. Okay. And at the same time, some of these costs, and a lot of the genome is done in North European and US populations. So there is equality of genomic analysis is still lagging, and there are efforts being made by various countries. Then we talked a little bit about the vaccines. That, I mean, all of you from high school onwards are familiar with Sack and Sabin, and Dr. Spector. Several of you have taken his classes, and the race that went on with polio and the march of dime epidemics that we talked about. And only 3 countries are left with polio now, and I know that is Syria, Afghanistan, and I think Laos, or some of the, just so polio is being virtually
Pakistan?
I'm sorry, go ahead.
Pakistan still have polio?
I think, yeah, that Pakistan is also there because of the scandal that was done during the Osama, this thing. So I think, but I think they're finally getting around to it, So yesterday, I'm taking Dr. Spector's class, and he did not include Pakistan. So I don't have the latest data on them. Okay, but Syria has had epidemic type of thing again. And so this is, and the anti-vax that we all lived through in the last 2 years, we talked about it type of thing. And, because the science we were learning it on the fly. So that's why we had a lot of problems, as to how the contagion was transmitted. Okay. And again, we talked a little bit about the transplant that started in the early 60s, from cadaver. And there was a huge learning curve that we went through because of the rejection type of thing. And so there's the transplant industry was followed with the discovery of drugs, and finally the great rapamycin was discovered in the fungus on Easter Island. And obviously the great Dr. Starzl pioneered, so he made Pittsburgh the Mecca that it is for medical tourism. And so it was a revival of Pittsburgh, that took place. Okay, so we talked about it. And thalidomide, we're all familiar with as to how one person, Frances Kelsey, stood her ground and prevented US from experiencing thalidomide disaster. And like it happens in medicine, thalidomide is making comeback for leprosy and for multiple myeloma as a derivative of a drug. So there is, again, so I'm trying to do compare and contrast as to how we are taking 2 steps forward, 1 step backward in medicine. Okay, and again, the prima donna heart surgeon, who's was made the cover of, and Dr. Christian Barnard, and he was, again, he was considered a little bit of a heretic because he never acknowledged the training that he received in US, basically, and just said, oh, I did this and I did that. And that's not how research is being done, because he learned on the shoulders of giants in US, primarily Dr. Shumway and Dr. Thomas Starzl, and who just carried on. And I think Dr. Joel mentioned the role of Dr. John Ackerman, who moved from South Africa to Tampa and did about 1,200 kidney transplant and kidney and liver transplant. Okay, so that was one of the pioneer work that was done. So transplant industry followed type thing. And again, the biggest advance that took place in women's lib was the discovery of the pill, right? And it was interesting that it was discovered from Mexican yam, and the research was carried out in the barrios of Puerto Rico because there were a lot of side effects, and it was never actually approved for contraception. But it said prevent menstrual irregularities, and that just opened up the floodgates type of thing. So this was, and so it was a very gradual increment of various hormones, and the trial was done in San Juan. Okay, and then finally the dosage and the problems that occurred with hypertension and strokes in women because of larger dose. So that was again a big learning curve that we went through, and now it has been adjusted to correct, and obviously with the morning after pill. And at the same time, the rise of advertisement and big pharma that we talked about. Some of you were in my class on drugs, opioid and drugs, and the empire that Dr. Sackler built with oxycodone and a derivative of sustained release morphine called MS-Contin. And it was, was the biggest tragedy of empire of pain. And in spite of efforts from various physicians, especially in the coal country in Virginia, it was just like, and he was a slick promoter of himself and his company and the small Purdue Pharmaceutical. There was a huge listing, and they got off with relatively easy. None of them saw prison sentence. They paid handsome fines, and again, and now this has been substituted by the fentanyl that has taken over. But the epidemic has went down, and my brother-in-law was working in Scottsburg, Indiana, which had the highest incidence of overdose from MS-Contin, and it took a lot of effort on the part of medical establishment for state of Indiana, governor of Indiana, to provide free needle exchange. And that had, it's a small city in north of Louisville, and one of the highest epidemic of drug overdose deaths. So it was a tragedy that had more deaths than a lot of other causes. So okay, so and again, so there are varieties of important technologies that we talked about. Some of the life-sustaining technologies versus diagnostic versus surgical. So the major advances, one can say that these are the various advances that we've taken place. So these are pretty self-evident, because, for example, without dialysis or pacemaker, you'd be dead within a few days, so to speak. So, and again, so we have made some tremendous progress in the last 50 years, that we need to give credit for that. And the biggest advance that came from UK was the in vitro fertilization that was again frowned upon by the religious establishment, but now it has become mainstay and it's a $3 billion industry. And again, we are still trying to swim against nature because the yield of successful in vitro fertilization is far less in a 39-year-old as opposed to a 30-year-old. And it is widely accepted type of thing. And again, we have crossed the threshold as to I could not believe that in India there was a 70-year-old woman who was subjected, who went through IV fertilization and had actually had babies with, like a in vitro fertilization of sperm and an egg, and and implanting the egg. So, but the cost of that is nothing to sneeze at, in cost into several thousands of dollars. So, okay, so that's basically what we had talked about. Okay, and so this is again varieties of ethical concerns that I think Ron may have a better funding to comment upon it. So again, so there is a various this thing, but in general, it's been accepted by the society as a rule type thing. So okay, and then again, the change in psychiatry that took place, and with the post-war, the Milltown that Joel talked about, followed by discovery of thorazine, which was actually used for anesthesia side effect. And in France, the people noticed, people were all of a sudden markedly calm. And then there was use for schizophrenia and other medication. And that just revolutionized, it put the Freudian psychology, to shame. And actually the pharmacological treatment took over, and then progressive increments occur in the psychiatric world. And again, and then when first with the antibiotics and with other Valium, it was marketed, the good old Dr. Sackler, that was a superb marketer. He started out sending out medical letters as free to thousands of physicians, and was made the Valium a very successful drug. I'm sorry, Librium, probably. That was the earlier. And again, so this was, and similarly, they were masters at marketing the pain relieving drugs. And at the same time, the medical community helped it along, because with the veterans, they discovered pain as a fifth vital sign. So in addition, a lot of physicians, well-meaning, started prescribing narcotics like candy, little realizing that the addictive potential. Okay, so this was, and so that really played right along, and the sales of some of these narcotics jumped into the billion-dollar category. So, and then again, that how surreptitiously medicine develops, that the drug that was originally used for treatment of chest pain, which was a vasodilator, means enlarges blood vessels. And some of the people said, yeah, but they're having erections. So apparently, so then Pfizer decided to market that as Viagra, because it didn't turn out to be that useful for heart disease, because there were other better treatments available. And so this has been in the big, so there were like, how many billions of prescriptions are written now for it? It's just and there was a very nice movie that was made about pharmaceutical salesmen, love and other drugs, So it's a finally nice comedy based on how the physicians who would not give a drug representative a time of the day started welcoming them and say, "Oh, I need this for a friend of mine." So it's an interesting story. And this and the sales and the drug representative, I can recall from my own story that when I was single in Green Bay, there was a new blood pressure drug being marketed, and they had offered me, says, "Yeah, we'll send you to Vancouver to attend a conference. We and your wife." I said, "I'm not married." No, you can bring your girlfriend along too. So and I think that was, I politely turned it down type thing. And before the Stark laws, other things, even when you went to the American College of Cardiology convention in New York, this one time it was in New Orleans at the time of Mardi Gras, and the drug company had sponsored a special show after 5 p.m. inside the football stadium. And so it was interesting to see all these Europeans wearing a bow tie, going and trying to run for the beads. So it was an interesting testing as to how much money they spent promoting their products, I think so. And then again, the speakers bureau type of thing. So, I mean, we had reputable physicians from Cleveland Clinic and Mayo Clinic coming for an evening talk to Green Bay. And at that time I was kind of naive. Said, why would these guys bother? But obviously they were handsomely rewarded by the drug company, and the subtle promotions that went along, where, obviously now we are learning that it's big, this thing. So, okay. Yeah, I think the chats are are by Peter and other stuff. So I think so they're obviously Peter has and Kevin has vast experience in the healthcare industry, in different capacities. So that's really, so I'm just looking through that. Yeah, sorry, I should be okay. And I think we can read them, at our time. So okay, thank you, gentlemen. Okay, so that was an interesting side break, I think so. Okay. And again, so drug, this was an important thing. So I have played a slide about the synthetic opioid overdose and the other things. So it's like you can see that the graph is off the chart from the national overdose drug, And finally, now it's being toned down a little bit with better explanation. But a lot of the overdose were probably, one can say, these were deaths of despair, people who did not have job and had aches and pains due to work-related or war-related injuries. And so those were the biggest tragedies that we have seen, especially in the Kentucky and Virginia, which had one of the highest number of deaths. Okay, and we talked about the chlorpromazine type thing. So, and the closure of psychiatric hospital has led to the homeless crisis. Okay, moving right along. The biggest advances that took place was the cardiopulmonary resuscitation, and that has that's been a big lifesaver. That even at places where a large number of people gather, the defibrillators have been the biggest advance that is available. I think so. So there are, we have made dramatic progress type of thing, and at the same time, the cardiology has been more fortunate in terms of getting advances and reducing the mortality and morbidity. In terms of, as opposed to, we were luckier than oncology. So, and after bypass surgery in 1987, the introduction of statins have made a dramatic difference. And again, and the criteria for treatment have gone from small to large to overprescribing to now being putting in proper perspective. And some of the multi-center studies were done that you get more bang for your buck if you have risk factors. So now there is a risk factor algorithms based on which we can decide how people should be treated. Because again, those drugs do have side effects such as muscle pain and other stuff. So how long people should be treated, that's still, it's left to the individual physician based on overall health and risk factors. Okay, moving right along, type of thing. So, and so this side, again, more data on the statins as to who actually benefits, type of thing. So treatment based on short-term risk versus long-term risk. And so there is definitely an impact that we have made, and that may be the big cause that we have. Okay, and in the 80s, we saw the HIV epidemic, I think, and the stigma that was associated with, there was this case of the kid who had HIV from hemophilia blood transfusions. And again, he was not allowed to attend school, again, due to lack of information and fear of contamination that went through. And again, finally, the Reagan administration was lukewarm in, attending the crisis. And this were the reports that came out in 1981, and it became a big cause after the superstar, the Rock Hudson, died. And then the patient-related activation played a big role. People started going to Mexico for getting the AZT therapy. Was made into a movie called The Dallas Buyers Club, and the patient-related activation that was done by Larry Kramer. And it, again, as it happens with viruses, the AZT, which was the initial drug, the virus quickly developed resistance. And finally, the combination of retroviral therapy was done, and the treatment of HIV has now become manageable disease. So it just goes to show you as to how, when we are focusing on the science, we do come up with this thing. So, and it's still, and the best thing that one can do is that the George Bush second administration did was provided drugs for Africa. And that's been one of the biggest boons in reducing the incidence. But at the same time, there are some crazy dictators, who are refused to believe that HIV was, worth treating. So Uganda and other countries and some African countries still continues to have problems. And it's an old disease, but still, so we are finally finding it handled, and even with the so-called morning after pill. Okay. And this was the Larry Kramer, where the patient-related activation, he, and some of this books that I've already alluded to, the band plays on. This was a book about the San Francisco epidemic, which was written by one of the reporters for San Francisco Times, and the band plays on. And the president did not get so much publicly utter the name until 85. And so this was, we have had huge number of deaths earlier. Okay. And finally, it is coming under some control. Okay. All right. So I think we're going through this thing. So, and again, we should advance that the stem cells, were big discovery that was done initially at University of Wisconsin for the embryonic stem cells, which are the stem cells are like any child born in the United States that has a potential to become president. So stem cells have a right to become embryonic stem cells can become anything that they want to be. Okay, so this is one of the stem cell saga, and you can just see it has the potential embryonic stem cells to develop into anything. But after 6 days, they lose their pluripotency capacity. And so now the easiest way to harvest stem cells was from bone marrows. But again, a dramatic discovery that was done by a Japanese researcher who discovered something called transcription factors. These are varieties of protein inside your cell, in individual cell. And there are hundreds and thousands of proteins which are there manufactured inside outside the nucleus by varieties of genes. But it took he systematically worked on for a number of years and isolated 4 proteins, which were called transcription factors, and they was able to convert an ordinary cell into stem cell. And so that was, and obviously it took a lot of effort on his part working individually, and those are called Yamanaka factors. So that overcame the objection that people had from the ethical consideration. So that has, and so there was a big dramatic shift as to how. So now the pedal can be pushed that it can, even a skin cell can be transformed into embryonic cells such as sperm and an egg. So there is a dramatic advances that are taking place, along with other discoveries such as, and this was a dramatic example of how stem cells have become made life. Okay, that people did biodegradable scaffolding material, and it was co-cultured with bone marrow cells, and a child which had a small deformity of aorta but from birth, and this was implanted. You can see that this picture is just phenomenal type of thing, that these artificially inserted transplanted part actually grows with the child, because otherwise if you put anything metallic, it is a problem, it cannot grow along with the child. So this was a huge plus that took place, and this was done, I think, in one of the Yale affiliated hospital. So it was a dramatic advances that have taken place. So we have to give credit for the pioneers who have worked with it. And again, as it happens, to point out the compare and contrast, there are a lot of fly-by-night clinics that are opening up, in not regulated or not conducting any trials and harvesting a few stem cells and injecting them. Hopefully they'll find the way where their defect lies, injecting into joints and into heart. And a while back, I had attended a talk from one of the cardiac surgeon who used to work at St. Pete, and now he's retired. And he was giving lecture at one of the Asian Indian learning weekend gathering. Oh, and I go to Bahamas and inject stem cells for heart failure. Are they part of any studies? No. And I'm sure they were charging like $25,000 up front, for people who were willing to. I won't give you the name of the surgeons, but he was one of the well-reputed surgeons in our area. So it's just one of the things as to how people are abusing some of the technologies, and obviously some of the celebrities have had benefit from stem cells. And again, we talked a lot about the gene editing and gene therapy, and okay, we had talked in the genetics class, and again, the ethics community, the genetic researchers community have done self-policing as to not to modify germline, and again, it took about 50 years for the Human Genome Project to come to fruition. Oops, I think, oh yeah, we're coming back. Okay. Yeah, all right, okay. Are you able to see my slide?
No,
You're
Okay.
off share. You're off share.
Yeah, I have.
We lost the share.
Yeah, I saw it. Yeah, thank you. Yeah, yeah, you should be able to see it now.
Yes, we can.
Okay, yeah, I had to do this yet again. Yeah, it flashed on my other screen for whatever reasons. Okay, all right. And so in 2003, we had the human genome, which was a competition between NIH and a private company called Celera Genomics, and Bill Clinton used his charm and power of presidency to get these two people together. And again, it took finally, after 20 years, the whole genome has been completed. And there were a lot of hopes and hypes that we will be able to, quote unquote, cure cancer. And again, as it happens that, it's still, a goal that we are striving for. But it has, with the genome analysis, we have made a dramatic progress. So again, it can be a whole lecture. But and again, there are a lot of omics, that my friend Dr. Johnny already did a talk on this. Okay. And hopefully you still have, still have the slide of omics. And I think, when he did the title, I think George Hyde, who's, who was promoting this class, had what is omics, so that means genomics, proteomics means analysis of proteins, epigenomics means analysis of the epigenomics. So varieties of data. So we are awash in data, and even the gut microbes can be classified due to genomic analysis, and even exposomes and what you're exposed to allergens can be done. So it's a brave new word out there, type of thing. Okay, and again, so this is the so-called evidence-based medicine is the big buzzword now. Okay, and it has, again, there may be more hype than hope sometimes. That we had hoped that we'd be able to reduce the cost, but again, that hasn't panned out as well as we thought it to be. So I'll have a few more slides to talk about later on that. Okay, and then this was, again, it's an older slide, but still very just to see. We have had, try to give home runs like we saw about Gleevec for the genetic biotechnology therapy. The cure for sickle cell disease has been a dramatic cure, and it made a 60-minute stories, But again, the prevention is a lot cheaper, but not as glamorous. Okay, I mean, preconception genetic screening, would go a long way in reducing the incidence of sickle cell disease. But I think that is a goal that may not be really reliable, reached type of thing, because I doubt very much if the 10% of population will agree for genetic screening and counseling beforehand. Okay, so we're again going for the more expensive route for curing the disease type of thing. So, okay, because it's a clear-cut single genomic disease, and screening and counseling, and that we have to give credit to the Ashkenazi Jewish community has done a dramatic job in reversing, like this certain diseases which affect that particular subset of population, and they prevented serious disease such as Tay-Sachs disease and other ones. Okay. Oh, absolutely. Yeah, Kevin's comment was right that the soldiers and even the truck drivers that go across, were big contributors to the disease transmission. Okay. Yes. Well said. Okay. All right. So I think we're coming up to the part that people who not. Okay. I think the strokes we already talked about as to how they were little late in accepting the clot dissolving therapy. But again, so now stroke is the time is of the essence, and it has made a dramatic improvement in terms of treatment of disabling strokes, because instead of permanent damage, we are able to salvage brain. Okay. And again, the most recent advances that we can just stop for is, the laparoscopic surgery, which we talked about, that started in the early 80s and advanced dramatically with the discovery of fiber optics. That I know Kevin probably knows more about it than I shall. But the more glamorous surgery was the robotic surgery, which the equipment is dramatically expensive. A lot of the hospitals are promoting it, like a sliced bread type thing. And when you look at the things, obviously not necessarily better than laparoscopic or even surgery, because sometimes, if the equipment is expensive and the surgeon is away from the field, and keep your fingers crossed that there is no cardiac arrest during the thing, because to remove all the equipment would be a dramatic problem with the robotic surgery. And again, there's a huge learning curve, and the kids who grew up with playing video games may have a better luck, because it's an acquired skill and there's a sharp learning curve, I think. But it again gives the chance of doing, surgery from distance, that somebody sitting in London can do surgery in Ethiopia or other countries. So there's, so we're taking 2 steps forward, 1 step backward. That's the point I wanted to get across. Okay. And again, so these are some that this is about as latest as I can give you type of things. So these are the trials that we are expecting in 2023. And the biggest one is the Alzheimer's drug. And it's still, it's been grudgingly improved, and the CMS is, standing their ground that they're not going to approve it as a blanket check to everybody. And the varieties of other trials that are being carried out, for weight reduction and other stuff. So, but I think, I will, for sake of time, I'm not going to go through each of them. And so we are, so finally we are done with the so-called progress in medicine, and I will get back to the area. So it took us about 30 minutes. So this will give the chance that people do not have to see the, oops. Okay, I have to start sharing screen again because it kicks me out from time to time. It does not like. Okay, I think we should be back in business. So this is where I was planning to start, type of thing, but now it is not necessary for you to go review the part 3. So, okay, all right. Now this was going to be start 3 of Rise and Fall with Dr. Joel and myself. And we're going to focus primarily on the US healthcare, the good and the bad and the ugly. Now, as it happens quite often, that Hollywood and movies are ahead in depicting the phases that we have gone through, because a lot of you grew up seeing Marcus Welby, the physician with the medical shows, to General Hospital, because as usual, as human beings, we have fascination with our health, rightly so. And the Hollywood and television has met that requirement. So we went from Marcus Welby to General Hospital to MASH. Now, I don't, being a physician, I'm not too attracted to medical shows. So I had to Google as to what are the popular shows. And believe it or not, I don't know what channel is it on, but there is a show now called Nurse Ratched. Okay, if you may remember her from One Flew Over the Cuckoo's Nest. So it goes to show as to how we have gone from admiring medicine to saying, oh, wow, this is a cruel nurse. And there is even a show called Dr. Death. And this is based on a true story. I don't know which one of the two, but there were a couple of anesthesiologists who were actually just messed up people and were bumping off patients. And that reminds me of, some of you may not be aware, but there was an anesthesiologist who used to actually overdose patients and kill his patients in OR or in recovery room in Illinois. And then when it became to news, they just suspended him, fired him. And again, the state of Illinois did not inform other states. So he just moved his practice to Iowa. Okay. And again, the death rate started increasing there. Okay. So finally, and so then after that, he decided that he had enough of the United States. And somewhere at one of the hospitals in South Africa, they were short of manpower. So they were glad to get a well-trained American surgeon. And sure enough, the incidence of death started increasing there. And I think, if my memory serves correctly, he was arrested when he came to get his visa renewed at JFK Airport. I don't remember the name of the physician, but that was a real life story. So we are getting to as to how we've gone from admiring physicians to fearing that. So, and that is where the television, just like in 2001 Space Odyssey, mimics real life. Similarly, in terms of movies, there actually was a movie made for the discovery of the first sulfur drug, and that was discovered by Dr. Elric, Magic Bullet. And that was a movie that was made, I don't remember the name of the actor, in 1940, okay, about Dr. Elric's Magic Bullet. I think it was Cliff, I don't remember the name, so I think I'm sorry too. And there was also a documentary made in 1957 about the great Dr. Albert Schweitzer, okay. But from that, we have gone to the HBO movie that is scaring the dickens of everybody, called The Last of Us. So how the movies depicts, how the trust in medicine is eroding. Okay, so, but there is some good news at the same time. I'm sure a lot of you read the Tampa Bay Times this morning, and this broke yesterday, that finally the CFOs and powers to be at Eli Lilly, the great pharmaceutical house, is getting some, and either it was the pressure from the government or not, because initially when the prices were fixed, that was only for Medicare people, but now it's going to be available for everybody. So there's a huge human story. So that will make some difference. So I think there is a lot to be said about the insulin cost being, we had talked about it earlier in the class second day about the insulin cost. So that's the good news type of thing. And again, as I don't have to tell all of you that, we're spending tons of money and not getting enough bang for the buck. And this is the data, just a couple of years older, but life expectancy and the cost. So we are number one in spending, at least. But at the same time, when you look at the life expectancy, we're not doing so hot, compared to other countries, in Western Europe and even Japan and Singapore. Okay, so we are outliers, spending as much as, and we're spending, I should say, probably 17 to 18% of our GDP on healthcare, and at the same time, some of the criteria that are assessed for quality of life, we're, because we're like number 33rd in, infant mortality, low birth weight babies, teen pregnancies, everything. So it's, so somewhere along the line, there is a big disconnect between what we're spending and what we're getting in return. And it is, okay, let's see, what do I have? This chap. Yeah, it could be that one, Peter. I think, thank you for looking that up. Yeah, it could be him. I'm not sure whether it was, I will look through that site, but yeah, it's quite likely. But I think there were more than one person, and there have been a lot of other people also who have really have had some serious mental issues, obviously, to get to that extent. Okay, and again, when you divide up the cost, what is the biggest ones? And obviously, all the actors involved are responsible for the cost. That is starting from hospitals to physicians to big pharma to the insurance companies and the device manufacturers. So it takes about 4 or 5 actors, working, to the disadvantage of general public type of thing. So, and the hospitals cost, that's the large big buck, because an average day in the US hospital costs anywhere like, up, I think last time I looked was like $4,000 type. So it's a huge thing type thing. And some of the numbers that you see are just staggering, type of things, that for simple labor and delivery. So it's very expensive to have a baby in United States, and even a simple vaginal delivery can cost you anywhere from 70 to 25,000. And if a woman has cesarean section, that goes up into the range of 40,000. Okay, and getting down to the simple procedure, which is diagnostic screening, i.e. colonoscopy, that is being promoted by, National Cancer Institute and varieties of physician organizations. Again, The other countries do it differently. They settle for a simple test called hemoccult. Okay, so the criteria for various developed countries are different. Now, it used to be an outpatient office procedure done under IV sedation, type of thing, and now it has become, a surgical center where the cost, which used to be in around $1,000, has jumped up to almost $10,000. Okay, so it's a dramatic thing, and one can divide that up into about $1,000 for the physician, gastroenterologist. Now, almost 2,000 plus for anesthesia. And get ready for this. There is $2,900 for something called facility fee. Okay. Now, again, so like the gastroenterologist community said, well, yeah, they used to do that under intravenous sedation, so they lobbied. But turns out that the lobby of anesthesiologists was a lot more strong. So that still has, being paid by your insurance company. So it's an amazing difference as to how the cost is divided. And again, this is healthcare is one of the few industries where you will not see price up front. It's like going to Publix and finding out that butter costs $10 and eggs cost $40 after you put them in your cart. Okay. And again, in terms of negotiations, it goes down. It's almost reminds you of a Westerner traveling to Egypt and buying a statue of the Sphinx with Arab street peddlers. And a price of 100 pounds could be negotiated down to 90 pounds, while it actually costs 2 pounds. So it's amazing how a simple iodine application would cost $20, or an intravenous bottle, which costs $1 to manufacture, we charge $100. So some of the numbers that we're seeing are just mind-boggling. And even as a physician, I was not aware that how much markup that was. Okay, yeah, it was interesting to see how many consults and how long hospital stay was for people with good insurance versus, yeah, okay. But at the same time, Peter, I think you're right in saying that a lot of physicians, they're being judged on their performance at their hospital stay. So based on quality of care items. So I had partners who were willing to send people home with low hemoglobin, but they didn't want to spoil their profile. And the surgeons were anxious to make sure that there's no readmission very quickly. So it works both ways in terms of, they want to, because they're judged based on that criteria. So sometimes having data is useful, but that can also backfire because physicians are afraid of having their name in the paper that they had a high mortality. Okay. And this is again, so this is why healthcare services are in chaos. And to be fair, the United States is not the only country that is a problem. All over developed countries, health services are in chaos, and obviously our fellow Brit can easily vouch for, and he can talk for hours on about the NHS and the issues that they have. Peter, if you have any comments or personal experiences from your friends and family, jump in type of thing about, and I think, and they were on strike. I don't know if they're still on strike, the nurses in UK or not, and again,
it's very patchy, Bharat. Some places are quite good and some places are pretty awful. And it's part of the way that UK healthcare has been divided up into coordinated care blocks. And it all works pretty much like HMOs over here, or how HMOs used to work.
Yeah. And going back to my notes, just going around the world, New South Wales, Australia, quarter of patients had to wait for more than half an hour to be transferred from paramedics to emergency room staff in 2022. Okay. Now, again, this was during COVID or so we have to make allowance for that. In Canada, the waiting time reached all-time high, waiting from almost 6 months between referral and treatment. And in Switzerland, there are fewer free intensive care beds than at most point during pandemic. Germany is saying similar problem with the surge in patients reducing ICU capacity. Okay, so this is, so there have been, all of the developed countries are seeing some crisis of one form or the other. And again, it may be that we're all getting older and the population is getting older. and the technology is getting faster. So one should not just pick on our issues here. So I think, but again, we live here, so we'll just focus on that type of thing. So okay, and so, again, about even after the Affordable Health Care Act, 11% of people still, and part of the rise of hospital cost has been due to consolidation as to they're bought out by and for-profit hospitals, which were almost an unknown entity before 70s, had become as many as 24% of all the hospitals are for-profit and owned by giant corporations, such as, that thing. Hospital Corporation of America comes to mind, and all of us are Floridians, so we know the Rick Scott saga, I think so. And this morning I looked up type of thing as to how his own investment was, and it maybe I'm off the thing, but he and somebody else had invested like of his own money 125,000, and they had borrowed like close to 60 million or something like that, and then this was in the mid 80s, and that was the start, I think. And the amount of fines that they have paid, was just exorbitant. And I have some data about that type of thing. So, and again, so healthcare, the hospital industry has been the big gorilla in the field type of thing, and all of us are very aware of the out-of-network errors thing. Okay, and this is the book that I relied on extensively, and I was just, and she has said certain this thing as to these are very cynical observations, but they're worth reading. You can read them at your own type thing. And we're always over treating a lot of the things. Again, we're similarly like we're choosing the most expensive options, such as colonoscopy versus simple screening type of thing. And again, we're treating a lot more chronic diseases with more and more expensive drugs. Okay, type thing. And again, in 1985, when we started direct-to-patient advertisement type of thing, and I alluded to about how several drugs for psoriasis are being competed upon type of thing, and even a simple skin depigmentation that people ignored are being treated with, with varieties of medications. So again, and healthcare is perhaps the only industry where having more doctors in the community does not reduce the cost, because there is something called the usual and customary fees. So that everybody's price has gone up, and you generally, unfortunately, you do not see the price. So the free market does not actually go around. And so, and again, like when doctors own equipment, that was, and I told you our own example that a new recruit that we were trying to recruit, he had told us that, nope, you guys are not good money managers. So he went somewhere else, But all the time, we did not own any equipment for ultrasound and other things, while some of the physicians had big $1 million cameras, in private. And so again, so that is a big dramatic difference that has, and I may be repeating myself, but the drug for rheumatoid arthritis called Humira, which has been around for 20 plus years, the cost varies anywhere from $19,000 at Beth Israel in New York to $98,000 at a private fancy center in Manhattan. And as if that wasn't enough, third time around, a few months later, the cost of the same drug, same dose, went up to $110,000. I mean, I just cannot believe that this is, and the insurance companies actually go around and pay for that, because, the New York hospital, they're a big source for, insurance, and they provide a lot more care. So it's mind-boggling as to how the same dose can be so dramatically different. Okay. And again, these are some of the projections that takes place that when we talked about the GDP, and we're somewhere where the line is, you see, and the projected cost, if you don't handle things, is likely to be going to the 40% range, Okay, so this is, and again, this chart is pretty, let's see if I can zoom in on that. Okay, percentage of uninsured type thing. And it develops into Native Americans, Hispanic, and populations. There's still a huge number of inequality type thing. Okay. All right. So and now we won't even, we'll get a little bit into the air ambulance business type of thing, and that's one of the biggest records that you will see. That sometimes one of the this I recall correctly, that somebody who had injury and needed rehab in what transferred to, because it was a Floridian, was transferred from Montana to Florida for a rehab facility, and the cost of the air transport was $650,000 for air ambulance. Okay, and the plane itself costs about $300,000. So this is, and some of the costs that are done for air ambulance, because those are not covered by insurance, and even statewide, the cost of average ambulance cost can vary as much as by $200 in various parts of Florida. Some of the data was like in Miami, it was $700 versus $590 in Tampa. So it's just, it's a free market to the dramatic type of thing. So, but again, at the same time, there are some private companies that are offering anywhere air transport in the United States for a fixed price of $20,000, and they're still making money on it. Okay, so it can be done, but again, there are small players, and the local markets has a huge stronghold on transport. Okay. Okay, I'm just reading the comment, Yeah, okay, yeah. The insured versus uninsured type thing. So, okay, there's I think, I'm sorry, I have to follow the thread. I haven't been keeping up with it. I mean, administrative cost. Oh, absolutely. Yeah, the markup is just unreal type things, and so the dramatic transformation that took place, of the hospital industry is just mind-boggling. And I have lived through that, in Green Bay type of things, that for-profit hospitals just came in, and Green Bay has a population of about 90,000, with surrounding area of about so close to 150,000. And we had 3 heart surgery programs, 3 emergency room, 3 dialysis unit. When I started out, we had 1 emergency room and 1 heart surgery program. And so it does not mean that the heart cases increase by threefold, but there you have it. So there were a number of hospitals, and they hired surgeons, and the transfer policy was just shocking type of thing, that about somebody who had a severe heart attack and needed work done right away was transported by air 75 miles, to the mother house, and obviously he had severe damage by that time. And some of the poor farmers, was at a small town hospital in Green Bay, and even though we had services in Green Bay 30 miles away, by air transport, he was sent to Milwaukee about 120 miles. And obviously, and when finally the farmer asked, can't you have anything done locally? And so it was just amazing. He was stuck with a bill of almost $50,000, not given a choice that yes, he could go 30 miles. Okay, but he was transferred to St. Luke's in Milwaukee, because the hospital in a small town on Lake Michigan called Manitowoc, had a contract with St. Luke's. So they were not told that they could go 30 miles with regular ambulance, but they were sent by air ambulance to Milwaukee. So it's amazing, the lack of transparency plays a huge role in increasing the cost. Okay. All right, I think we're moving right along, I think. And, this is again, the role of hospitals, this is, again, obviously the big claim that the hospitals have, that they are providing charity. But again, that when you look at the real numbers, their claim sounds hollow, and I'll have a slide, I think, later on, as to how, in the consolidation in major cities, about just 2 or 3 large systems control a lot of the things. So, and the cost of some of the services between 97 and 2000 have gone up 150%. Okay. Then there was an example that I read, one of Marty McCurry's book, that a physician while operating had a needle prick, because the needle went through the gloves, and obviously for screening for HIV and other stuff. So had to go to the emergency room because of the OSHA rules. And that simple needle stick care, where they just cleaned up the area and was seen in the emergency room, was $3,400. So it was, it was an eye opener as to how simple having 3 stitches can end up costing you $5,000. Okay. And this becomes a problem. The worst problem occurs for people who are paying cash, and especially, so that is just it, so there is no way the transparency, it continues. And there is something called the charge master, which is a big reference manual that hospitals use, where you could have a $30 aspirin and and a $100 IV bag. Okay. Or even a simple Tylenol with codeine, which is a simple pain pill, which you can buy for 50 cents. You'll be paying $25 for it. And so, and again, so this is, and finally, when you're sent to collection agency, they can be pretty tough customers. And we talked about the smaller hospitals, even the charity hospitals are not above suing the patient for collection. Okay? And in fact, they are some of the worst culprits type of thing. So, okay. And again, so this is, in some of these buildings, are palatial, so to speak, that they have, like one of the hospitals in Green Bay had a grand piano and with a cafeteria that equaled one of some of the best restaurants in Green Bay. Okay. So it's just, so the whole spectrum has dramatically changed. Okay. Let's see now. Okay. And the rise of, just the simple administrators, like the CEOs and business models type of thing. So they have taken over, and in the last 20 to 30 years, so to speak. So, okay. And again, when Medicare devised the coding system, and the hospitals have learned to game the system as to how to upcode the visits. And that again, like we were always chastised, a type of thing as that, that anybody with chest pain becomes a level 5 automatically. And I was to say, well, that wasn't that serious. I could easily tell this was not hard, but still I was encouraged to code. I used to be called by the medical records department. Oh, you're undercoding things, and me and one of my partners were always being, picked on for undercoding. Okay, jump to the first unread message. Okay. Oh yeah. Okay. So this was, one of the things as to how the numbers trends in hospitals. I mean, these numbers are staggering type of thing, is that the number of community hospitals have actually decreased, but at the same time, the length has decreased. Still, the costs have gone up dramatically. So on one hand, and some of the smaller hospitals have folded, but still the cost that we're paying is, continues to rise. Okay, and they've closed a lot of the psychiatric hospitals that we saw, and some of the hospitals have been stopped doing labor and delivery. Okay, because it wasn't cost effective and wasn't a big. There's a lot more money to be made about doing orthopedic surgeries. Okay, and the big argument was that they are training residents and physicians. Okay, and now let's look at some of the statistics for that. The government pays almost $250,000 to train people. The salaries of even the most senior residents anywhere from $60,000 to $80,000. So there is a huge amount of subsidy. The actual cost that hospital may incur for training is about $130,000. So again, so they're making out, even though they say that there is a cost for training, but they're being handsomely rewarded for it. That I think so. And at the same time, in spite of the new laws that have been passed for how many hours a resident should work, that still, I have cousins who are working, and they're working anywhere from 75 to 80 hours per week. Okay, and then again, there's a hierarchy in the system that some of the senior residents, even though they should be showing up to support the junior residents, they just take off, and they're left with inexperienced people. And again, as you may realize, that sometimes you're admitted for observation, that is not covered. And that always used to irk me, type of thing, that hospitals had something called the chest pain detection unit, We're coming up to 11 o'clock, so we should take a break. And after I finish this slide, just realized that the time is running short. Okay, there is the observation status that we had something called chest pain unit. So people did not even ask questions, the ER physician. Okay, anybody comes with chest pain, they go in the observation unit. The hospitals loved it because they were there overnight. There was a billing for the emergency room and the observation status charges. Next day, they got a big $5,000 nuclear scan, okay, which was monitored by nurse practitioners and was read by the cardiologist. And to my chagrin, even some of my own partners did not want to go down and give the results directly to the patient. They would call the ER physician, okay, and just say, "Oh, give the results." And their patients were supposed to go to the primary care doctor. And a few times, like I used to usually go down and give results myself. And this incident comes to me, type of thing, that a woman who was 70 years old was admitted to the chest pain unit. Oops, I think, oh, I'm losing my share screen. Okay. I think the second monitor times out. That may be the problem. So let me finish this story and then I will stop my monologue. Okay, so I went there, and this woman's daughter was there. She says, "Yeah, but my mom still has chest pain." And I just went and just talked to her. Clearly sounded like gallbladder. And so I ended up, admitted, say, "Oh, yeah, this sounds like gallbladder pain. I don't think she needed this big thing." So I ended up admitting her, type of thing, and called the surgeon. Patient had gallbladder surgery and went home safe and sound. Otherwise, that would have been delayed, type of thing. So it was so it was an interesting experience as to how people did not even ask simple questions as to what the pain was like, the description that, you should learn about it, But the ER guys were obviously, to be fair to them, they were swamped with 40 patients and they did not have time to sit down and do a complete history for 10 or 20 minutes. Okay, so I think we'll come up to 11 o'clock and I will stop my recording and we shall come back and resume recording. All right. Oh yeah, I just put this in, we were talking about charity and this was eye-opening type of thing as to, this says, California Pacific Medical Center is, is a big hospital chain type of thing. And look
Can you enlarge that, Bharat?
I'm sorry?
Can you enlarge that? It's very hard to read.
Oh, okay. Oh yeah. Can you see it now?
Yeah, little pieces of it.
Oh,
Yeah,
Your whole slide needs enlarged, your whole
Yes.
video.
Oh, okay. Oh, yeah. Let me see which one I'm sharing. Stop share, and maybe I'm sharing the wrong one. Yeah. Okay. Just a second. I think I maybe share screen. Oh, yeah. That's why. Now you're in business.
Okay, now you can make it small.
Perfect.
That's better. Great.
Yeah, because I'm sorry, I was sharing this screen 1 instead of screen 2, so that's why. Okay, you should be able to see the slide now. Okay. Yeah. Okay. Yeah. Sorry, I was sharing screen 1. That's why it was a small one. Okay. All right. Yeah. So this is, like the big centers in California, the California Pacific Medical Center. And you can see, their income is nothing to sneeze at, out of 200 million, the charity care was, 16 million. So you can't say, even the great Stanford University, and they just recently just built an almost $800 million new hospital, and because of my cousins, I get their information. It's almost like a palatial type of thing. You can just say it equals Marriott, the building type things. And same way, you can see the other hospitals, we've seen that they're, so, and at the same time, that what they're charging, that the insurance companies, that the contracts and the discounts that they have a gag order, so they can't talk about it. So a lot of times, it becomes like a bigger than the, Trump's tax returns, so you cannot find out what exactly it is, It's a huge problem type of thing. So again, and this was again, and it almost makes you cry, so to speak, as to how they can garnish wages, type of thing. That this was, and this was, having worked in Wisconsin, I could see this was a slide that I shared with some friends in Wisconsin that, the rising from, garnishing wages from 1.1 to 1.5. So it was like, so, and being sued for, bills. And, which is again, which are jacked up bills. And again, the co-pays and other things can really, throw you into bankruptcy very quickly, type of thing. So, and okay, starting in new protection laws that have been implemented. So this new protection will ban surprise bills, type of thing. But if you're uninsured and you decide not to use services, you can get an estimate of cares up front, and you may be able to dispute the charges. But a lot of people are not savvy enough to question, and when they're threatened that their credit may get affected, obviously people would end up paying, in small increments, type of thing. So this is the amount of medical debt that people have is just staggering. That, I mean, I may be repeating myself, but 1 in 4 cancer patients, have to almost declare bankruptcy because of their hospital bills. I think so. And again, getting down to a little self-examination doesn't go it's worthwhile. Role of physicians in terms of, I mean, there are like 850,000 physicians in the United States, but again, we have maldistribution, Okay, so that averages out to 2.6 MDs per 1,000 people, but 40% or 45% are in primary. But when we look at the distribution in Massachusetts, it may be 3.5 per 1,000, but when you look at Oklahoma, it's 1.9. Okay, but again, even with quote unquote cost of medical education and the debts, not much reason to feel too sorry for doctors, so to speak, because the average salary, but when I joined practice back in 1980 was 40,000. Okay, and now the starting salary of a physician is anywhere from between 250 to 299,000 per year. Okay, and when we are trying to recruit cardiologists, that there was, it was again, that were going to the range of, so for subspecialty, it was going into 300 to 400,000. There are 154 medical schools in the United States, which produce about 20,000 graduates, plus throw in about 6,500 doctor of osteopathy, which now, they are hired without any discrimination that it was there back in the 70s, everything. And again, that gives me a bad taste in the mouth, because I had a training position at a better hospital in Detroit area, and I was promised that, yes, and it was in November or December that I was promised, okay, yeah, you're one of the good residents, you are sure in for cardiology. And then sometime in February, the chief called me and says, we have these exceptional candidates, we have to take him. Okay, and because they got a lot of referral from nearby osteopathic hospital, they recruited him. And so that kind of left me with a bad taste in the mouth as to how, some of the smaller hospitals decided training programs. So
Kevin has his hand up.
oh yeah, please go ahead.
Yeah, I'm certainly not an advocate for the salaries that physicians make, but if you look at the numbers you cited, Bharat, if in 1980 was 40,000 and now it's 250,000, that's less than 5% average increase in income. So I think we ought to keep that in mind as well.
Oh yeah, no thanks for, yeah.
People think, oh my God, but huge, but it's really not.
Yeah,
And just a
no,
few years ago.
Yeah, no, I think I can understand that. And then also the whole thing is like how much, I mean, I was always kidding my son, who started a job at, at one of the Epic software company, for a 22-year-old with just a bachelor's degree in math and computer science, he was being offered like 80,000, starting salary. And when he started working for Amazon, it's just mind-boggling. I was just had to say, David, this is a highway robbery, that we're being paid more than a starting pediatrician, just with, 5 years of education. So and along with that, the stock option thrown in. So I think, so yes, it is a big thing. So excuse me, I think I was just saying. Yeah, it was. Okay, yeah, I'm sorry. Sorry for the interruption, but otherwise it would keep ringing. Okay, so but it's, it is, it's like, okay, then now the distribution is changing that, like more than 40% of the new graduates are women, and the foreign medical graduates, which is nowadays the term is revised to international medical graduates for whatever, reason, it's about 25%. Okay, and again, now they just give you some statistic of nursing there are about 4 million nurses, and that divided into 3.4 RNs and another 250,000 nurse practitioners. The average salary for nurses is about 70,000. Nurse practitioners about 105,000. Okay, so it's just so this just gives you some idea type of thing as to how Okay, and then again, there's a big lobbying effort that goes on from the AMA and the specialty society. So in terms of deciding quote unquote usual and customary payment, I think, and again, Medicare is trying again to reduce the payment, but some of the lobbying power is dramatic. I'll give you the example of cataract surgery that Medicare has kept lowering the payment type of thing. And they come up with newer and newer technology to, sort of, promote different type of lenses that are being planted, which sometimes patients pay out of pocket. And again, the amount of time that we spend, because for example, let's take a heart surgery. A heart surgeon may spend, 4 hours doing bypass surgery. And the same time, people who are doing cataract surgery can get done with 12, okay, and be on the golf course, So when the freestanding eye surgery centers opened up, I used to just jokingly call it as to, yeah, this is the cataract palace type of thing. So it was an amazing how certain procedures, and there are people who are doing tonsils, they were done by noontime, they would have done 7 or 8 cases by that time, So it's how this is startup thing. And even for anesthesia, like people who are doing anesthesia for tonsillectomy, they, considering their remuneration is a lot higher than, so we had difficulty in finding anesthesiologists who would be willing to do heart case, because they were making more money assisting other surgeons, people who are doing a low risk surgery. So it was a really screwy system that we could have a surgeon available, the patient available, but they couldn't find an anesthesiologist because they were not willing to do the smaller cases. I mean that the less rewarding cases. Okay. Yeah, and yes, yeah, I don't know who's come. The new CMS hasn't got around to pricing properly. Yeah, yeah, it is. Yeah, so let me get my headphones on. Good. My wife is trying to negotiate price of her drugs. Okay, all right. So this is just some of the data type of thing. So and then again, what happens is that how in sometimes the anesthesia groups have devised a system of supervising CRNAs, and so sometimes you end up getting double billing type of thing. So and then the biggest difference that has made is to how people are having equipment in the office. So they're charging for the owning the equipment. So that has become a big rewarding system. I give you the example of owning fancy nuclear cameras or even ultrasound machines, that it pays for itself very quickly type of thing based on the procedure chart. Okay. And so this is one of this thing. And again, now different views about malpractice, that the physicians claim that, they're paying. Yes, it's true. Some specialties are paying a lot for malpractice insurance. But again, the premiums have not gone up that dramatically for certain specialties. And again, as to how one practices, that how honest we are and how we are communicating with our patient has a huge influence in terms of, like if obviously medicine is far from perfect science, and we're going to have some bad outcomes and this thing. So, knock on wood, in 30 years, I've never been named in a suit type of thing. So that was, and again, because that may be just pure dumb luck, but it just goes around type of thing that's, and because it's seriously that, even though you may do everything, but and some states have a lot worse climate for malpractice than, because I know of a physician whose brother was in Illinois, and he could not move up to Wisconsin because if as long as he stays in practice, he has to pay something called tail. So he has to keep paying for the insurance payment still in Illinois. So he was absolutely, literally married to Illinois because he could not get out. If he retired, then he would not have to pay the so-called tail to the compensation fund. But so it was one of the things. So some specialties have a lot worse than we do, type of thing. So and the premiums vary vastly, type thing. And again, this was I could not resist putting in this slide about the free screening, how some of the vascular surgeons were doing it, a lot more less resource poor areas, is offering free screening at churches, and then leading to further testing and sort of needless angioplasty or bypass surgeries, I think. And so, and again, that this was another thing, that there is a test for heart disease, which is called calcium score, which tells you the calcium that may have built up in your tiny arteries that supply blood to your heart muscle. And this calcium score, again, that we're looking at anatomy, but it does not correlate it with your physiology as to whether the blockage is significant or not. So we're looking at, and I used to have patients who would vacation winter in Arizona and, oh, I have the calcium score. Okay. And these are the people who have established heart disease, that's and I had to joke that this is like telling a woman who has had 3 children, has a scar has a stretch marks on her belly. But it was, oh, my calcium score was 700. Says, yep, you've had bypass surgery, you should have a high calcium score, type of thing. So it was, a lot of time it was being promoted, at a discount or like a attractive prices for having a sale, So I used to see this big 8-column ad, come and get a calcium score, for your heart, for your neck, type of thing. So some of the promotions were just way off the top, type of thing. It was one of the tragedies that was going on. Okay. And again, the impaired physicians, that is a big problem. We already talked about the real outliers who are actually killing patients. But at the same time, substance abuse is still a this thing that is underreported. And again, there is like a mafia type structure that if you ask in any hospital, physicians know who have the bad outcomes and who results are poor. But there's like a code of silence. People would not talk about it, type of thing. And supposedly the state medical boards and the medical societies, they're supposed to police, but they're very lukewarm about doing this thing. So, and then again, some of the physicians are absolutely, hard in terms of communicating with, with patients and with other staff. And again, I've seen that, we went through this thing just to reminisce from this thing, that we had anesthesiologists who were actually, had gone through drug rehab and they were welcomed. And a lot of the other surgeons were saying, oh, yes, he has a family to support. So, they were being welcomed with open arms, type of thing. Whether they'd actually recovered or not, that remained to be seen. And then we had, 2 competing heart surgeons. One surgeon, and there were a lot of multi-specialty clinics. So one heart surgeon was a very affable and nice, gentle personality, and used to give nice Christmas parties, and would ask any general surgeon to assist. And obviously, there is a certain skill in terms of harvesting a vein for graft. So his results were, generally very poor because the pump time was a lot longer. While the other surgeon had a personality of a peapod. Okay. When I would refer him the patient, I had to warn patients, don't expect him to say hello to you. You stand at the bedside, look down, and join his hand and say, oh, Dr. Pathy just said you surgery, you need this, you're scheduled for tomorrow. We'll turn around and walk away. Okay, and that was his bedside manners, basically. And I had to warn the patients that don't expect, good big this thing, they're sitting down at the bedside and talking, But his results were just phenomenal, I think. And all of us who have worked in the healthcare field, we know this, type of thing. And so it was, so that's a big discrepancy that there is, some of the stories that I hadn't thought about for a while comes back to me, type of thing. And again, both sides have the problems, type of thing. Physicians have the God complex. And this was, I thought this was a very nice slide. I don't know where, I think I saw it in one of the research articles, and this is, physicians, like, especially some of our surgical colleagues and even some of the cardiologists have the cloud of playing God type of thing. So, and I had a colleague, who used to actually just use the word, okay, to convince patients for surgery and other things. It would say, you're going to die, and you would just walk away type of thing. So it wasn't like giving you choices type of thing, it was very outspoken, person type thing. And at the same time, a lot of time patients also have a lot of doctor shopping and not fault and manipulation type of treatment. So both sides have, have their issues, but you could read the pros and cons type of thing. So, okay. And okay, so these are, it takes two to get a good outcome type of thing, in terms of, and a lot of times, like people would, we would be looking for any bad outcome would be considered like, a good this thing. So, and we've seen the ambulance chasing lawyers and their role. Okay, and this just gives you an outline of, I thought this would be an interesting thing to share, about what specialties are a lot more rewarding, and the plastic surgery, which is again, but there is a long training, one of my family members is a plastic surgery resident, and it's a 7-year surgical program, and even just to get board certification is probably one of the most complicated board certification that I have seen for plastic surgery. They have to not only do cases, take pictures before and after, and present it to be qualified to take oral examination for a plastic surgery board. Okay, so some of the oral exams for, and which is even so more complicated than neurosurgery, because I have 2 family members who are in plastic surgery and neurosurgery programs. So those trainings are extensive, and a lot of the universities are now asking that people not only just do the training, but they spend at least 1 or 2 years for research. Okay, so it's a very long training program. So it's just to be fair to them, everything. So, but these are some of the salaries that are in, but when you compare with the other countries, it's like, we are again, it's a huge difference. For whatever reason, Luxembourg is the income is substantially high. So again, and the last one is Poland. I can see that. So this, it varies depending upon various developing countries, And again, which specialties are poorly paid, pediatricians, psychiatrists, and public health, obviously, is way at the bottom. So it just gives you some idea type of thing as to how, and that affects what people choose when they are in training. Okay. The credential committee meeting, yes. Okay. Oh, I did not know that. Kevin had a nice comment. The largest continuing course by far for dentists is practice building. Yes, I did not know that, but thank you for sharing this, Okay. And okay, so now, now it's a chance to talk about the other big factor, which is again 20% of the $4.3 trillion cost, and the biggest paradigm shift was the pays directly to advertise type of thing. So, okay, and again, for a more expensive brand name drug, they were enticed with coupons for copay, but at the same time, your insurance company ends up paying for the more expensive drug. So that's, and then again, something that some of you may not be aware. PBM stands for something called pharmacy benefit managers. That's a whole new category of in-between people, who skim off the top, and the other games that is that a lot of time the big pharmaceutical houses will buy up the small generic companies and would delay the release of the generic drugs, or marketing in a different form, is to like either a more sustained release or different coating type of thing. And even some of the generic drugs are not as cheap as one could be in other countries type of thing. So there are huge things. So, and similarly, one drug that comes to mind as to how they expanded the indication for the well-known antidepressant drug called Prozac, and originally it was marketed for severe something called endogenous depression that is biochemically related. But then they expanded the indication for something called situation-related depression. I mean, obviously, if you were dead in the family or something like that, I mean, you're going to be sad for a while. But to look for that for relief in chemistry instead of getting counseling or therapy type of thing, the indication was expanded. And unfortunately, what we discovered that when you stop the drug, you feel really lousy. Okay. So again, so you're kind of more or less hooked on it. So the story of Prozac, is something that is. And now when you look at in last 20 years, when you look at the drug trials, a lot of times I look at the bottom as to who is paid for it. Huge number of drug trials are paid by the drug company. And unfortunately, what happens that, they seem to own the data. So sometimes, if there are negative results, there are not, the data is not published, the trial is not reported. Okay. And again, when they do comparison with the competitive drug, the system is gamed, so to speak, that they're comparing with a lower dose of other drugs so that their own product looks better. And this was interesting that I don't read psychiatry papers, but there was one drug, which I don't recall the name for schizophrenia, and several companies were marketing it. And they all came out with a different conclusion that their own drug was better than their competitors. So it was an interesting how it just goes around how, okay. And again, unfortunately, as a customer, you have very few choices that you are awaited. I think you can shop around, if you're lucky enough to live near the border, you can cross over to Mexico or Canada or import drugs from elsewhere. And again, like if you see overly advertised drug, one has to be careful that, probably that all that glitters is not gold type of thing. And again, our FDA needs to revamp some of the patent formulas, because obviously the cost is substantial for development, perhaps, and so, and finally, we are seeing some light at the end of the tunnel that over the next few years, Medicare is going to be able to negotiate, prices type thing, but it's going to be a very slow and incremental process. So how that will help you and I, that remains to be seen type of thing. But there is some effort being made finally about negotiating the prices, and because the other countries are doing much better. Now, obviously, those of you who read the scientific philosophy, I may have talked about it in other places. Now, this is what I had promised we'll talk about it when Joel brought this up. The paradigm shift in medicine, which occurred with, with stomach ulcer. And it's a very well-known story about how Dr. Barry Marshall ingested the H. pylori, himself, and sure enough, he got ulcer, and that changed the whole ulcer. Joel told about the story about the ulcer disease. Now again, the H. pylori, with the widespread use of antibiotic, the Western gut does not even have that until you're symptomatic, and then you have the infection. At the same time, the bug H. pylori, Heliobacter pylori, has been around since we started walking on the savanna got down from the tree. So a lot of the times it's present in the African gut. If you do the gut microbial study, it's around, but somehow it's like an enigma that they don't get the ulcer and the thing. Now, why am I putting this up? Because obviously this is a well-known story. Because when they came out with the acid inhibitory drug, the biggest one that you may recall is called Zantac. That was cleverly marketed by Glaxo Pharmaceuticals. That they formed something called the Glaxo Digestive Institute, and paid various physicians and a gastroenterologist to research, type of thing. So they decided to give, like a breakfast to the runners, and obviously they got a little bit of a heartburn. And simple. I mean, who hasn't had heartburn? Obviously, a lot of you remember the story, the plop, fizz, which was controlled with simple antacids. So we changed into a new disease which we created, and I'm sure, the disease is named GORD, G-O-R-D, in UK, and as in the United States we call it GERD, gastroesophageal reflux disease. So simple heartburn we created into a new disease testing. And Zantac was one of the first billion-dollar drug, which it was marketed very cleverly by Glaxo Pharmaceuticals. And obviously the Brits spell it differently. They spell it esophagus with OE, so that's why it's called gourd in UK, by the way. Okay. And similarly, simple postmenopausal symptoms, a lot of women have experienced, that is now labeled as premenstrual dysphoric disorder. And simple, some people have different personalities, shyness, that we have labeled as social anxiety disorder. So that is being treated with varieties of medications. So we've created a disease where there weren't any type of thing. So now again, whether disappearance of H. pylori as it related to other epidemics of other diseases such as your autoimmune diseases or not, that remains to be proven. So the whole association for H. pylori, okay, yeah, I'm sorry, just got a message from Jay that he had to leave. So, okay, yeah, I will be sending the recording, Jay. So if you're still on, yeah, no worries. Okay, all right. So that may have some relationship with autoimmune disease that we have applied, including. Okay, so it may not be cleaning. Similarly, another story that I bring to mind, you may have seen the campaign for purple pill Nexium. Okay, so that was an interesting story that, when the proton pump inhibitors were marketed, the first drug was marketed, the name is not that important, called Pralosac, which is now over the counter. It's called omeprazole, if I'm mistaken correctly. And they started playing out with a similar drug, which, for those of you who remember their physical chemistry, which is, like a mirror image type of drug. And they started with brilliant marketing with different doses of marketed 20 to 40 milligram doses with changing in subtle analysis of your hormone gastrin level. And so this was basically, similar drug, but and it was marketed with the name is called espromazole. Okay. And that marketing campaign, the ads were taken out as to how our drug, the so-called purple pill, was more effective for erosive esophagitis. You can see the dose, 20 milligram of Pralosac, which was the original drug, was compared slightly longer dose of Nexium, and that made Nexium, and it, the sales for Nexium were dramatically high type of thing. There was in cost of billions of dollars. So it's a very clever marketing ploy that was taken out by doing comparative study. And I'm sure all of you remember the study, the so-called purple pill was advertised. So we went to a more expensive drug. Similarly, okay, celiac disease, which was actually sensitivity to gluten, which was, which was there in Western European and Caucasian populations. The incidence was, 1 in 2,000. Okay, and then again, that somewhere along the line, people started doing, this thing. People who had non-specific symptoms related to this. So a whole new disease was labeled by various gastroenterology conference that took place in Ireland, and they decided all these symptoms had related to wheat this thing. So a whole new disease, this thing was created, non-celiac gluten sensitivity. Okay, and the name was coined as to see whether some of these symptoms were related type thing. So, and so a lot of papers were done, and that exploded to the big market of gluten sensitivity. So, and I'm sure you've seen as to how the gluten business has exploded type of thing, okay, dramatically. And the varieties of books that were purported, but there is a doctor that you may see on public television when they had the fundraising. There's a doctor named Dr. Paul Mutter, I think, and he wrote a book in 2011 called Wheat Belly and a Grain Brain. Okay, and that exploded the craze for gluten sensitivity. And believe it or not, this almost blew my mind. There is even a gluten-free shampoo. Okay, so I could not believe it. This was fun learning. This was 2013. Okay, then again, we have these campaigns that we created for raising awareness for the disease. Like for example, my disease is better than yours and deserves more attention. So you have this campaign about awareness of disease, and obviously, I think, all of you are familiar with the so-called ice bucket challenge, that, I don't quite remember what I type thing. So this is, so the glamour of the rare diseases, has become, but at the same time, some of the common diseases, such as alcoholic liver damage, that is not as glamorous, type of thing. So it's still languages, there may be more people dying from alcohol abuse or gunshot wounds, and we don't focus on that. And again, and just to be cynical, do we really need quote unquote sepsis awareness day? I mean, any doctor or nurse, would know what measures one should take, type of thing for awareing sepsis, so it's just standard medical care. So we're creating a lot of these campaigns, and while well-meaning support groups, may sometimes go. Okay. And then again, this gives us idea, obviously all of us understand that treatment guidelines and checkpoint lists are a very sensible way, like, for flying a plane, you need a checkpoint list type of thing. So it's a very useful in surgery for avoiding complications, not operating or leaving a piece of gauze inside your belly. Okay. But at the same time, we are losing some of the practical things, that there were rules in hospitals that you had to change the intravenous lines every third day, and that was really a pain in the neck type of thing, especially when you inspect the slide, and some 90-year-old who had the intravenous lines and are just basically dying, and you're required to change the tubing every 48 to 72 hours, that thing. So sometimes some of the treatment guidelines, were backfiring on us. Okay. Varieties of other drugs, type of thing as to some drugs, which were introduced in the market, reintroduced, and as to how, this was a drug which was marketed for irritable bowel syndrome and constipation that works on, the hormone tryptophan in your intestine and had improved symptoms. And again, it was approved and then again removed because of complications due to heart disease and was again reintroduced and was again withdrawn. And you can just see the advertisement campaign, with these attractive women, where the traditional drugs, which were a lot cheaper, were, being underutilized, And again, I may have told the story again about the simple sulfa group related drug, which was helpful for irritable bowel syndrome, that they changed the packaging to a longer release and had raised up the price of it. So again, so these are, and okay, this brings us to, I think Peter may know about the drug Neurontin. Okay, so if you have experience with that, you can share that. Feel free to jump in. He knows more about epilepsy, about Neurontin, and how the pharmaceuticals, in this case Pfizer, had promoted the drug for off-the-label use, to a large extent, for shingles pain on. For other depression, neuropathic pain. And so this was, and finally, Kaiser Permanente, which is the large insurance group on West Coast, had sued Pfizer, and they won like a $47 million settlement for promoting the drug. Okay. And so this was, and people who were had more withdrawal symptoms because they had problems with hallucination and photophobia. So it was like an off-the-label Neurontin settlement that Pfizer went through. They shelled out, $430 million for promoting off-label use. Okay. So you can just see how much their income must be. This was one of the companies that Pfizer had bought from a smaller company. And Neurontin was widely promoted for, varieties of symptoms, which really had no clear-cut data for it. Okay, I think we have 10 more minutes type of thing. But at the same time, they do some good things type of thing. So this was, some of these pictures may be a little bit not for the faint-hearted. This illness, which occurs in developing countries called river blindness, which occurs due to a worm, okay? And this is even a more impressive picture. This is an illness called filariasis, which is a mosquito-borne illness that occurs in Southeast Asia and Africa, which is a huge thing. And again, one has to say that there is a medicine for this that the pharmaceutical, I think it was Merck in this case, they provided free of charge to various sub-Saharan African countries for river blindness and lymphatic filariasis in collaboration with the World Health Organization. So these drugs have been, targeted, and we are making some impact type of thing. So about several of these drugs have made significant progress. And again, and some of the Latin American countries, such as Colombia, Ecuador, have been able to actually eliminate this river blindness illness, which was endemic in their area. Similarly, lymphatic filariasis, which is the big elephant foot, has been eliminated in various other countries. The names may not be familiar to you: Togo, Yemen, Malawi, so various African countries, and in the Arabian Peninsula has been eliminated. Okay, so that is, so they are doing their share, and the Bill Gates Foundation is doing exemplary work about providing malaria vaccine. They're not as effective as one would like to be, but we are making impact on chronic illnesses in area. But at the same time, they have the share about promoting the drugs, and even the so-called respectable, journals are not about falling victim to, not publishing the bad outcome. Some of you may recall the drug called Vioxx that was heavily promoted for arthritis. Okay, and the data were becoming available after it was marketed. That let's see if I can read this. Okay, I think yeah. Oh yeah, here the molecule was discovered in 1994 and was approved. Okay, 95, and once again became very widely available for better than usual aspirin and morphine type this thing. So, and the indication was expanded for intestinal polyps. But as early as 2001, there were suspicious data available that had higher incidence of heart disease. And a Seattle pharmacist had written a letter to the New England Journal. Okay, but again, the journal, in its infinite wisdom, decided not to publish it. Okay, and the drug continued to be marketed and sold, for several years afterwards. So again, the big publishing, the reputable journals are not above falling victim to the pharmaceuticals, because again, the advertisements have a huge role to play when the studies are published. So again, and the same thing happens with other things also, that the publishing industry is not without its share of. Okay. Now, I think this is, you're not going to be able to see this slide, so I think I'm not even going to. These are some of the cancer drugs, that their prices. But the one that is coming up, this is probably more legible. Again, so I apologize for the off-color things because I was too lazy to print everything myself. Okay. These are the varieties of cancer drug, and you can see the prices of drugs. These are blood cancer. Annual cost of these drugs. Okay, you can see that starts out from a low of 180,000 to 250,000. So some of these cancer drug prices will average to $325,000 per year. And again, if they're administered by the physician's office, then the cost may be even lower. So how this will pan out, and again, just to reiterate as to how the cost of the new Alzheimer drug, that's being marketed $26,000 per year, and you have to be taking with the early onset of symptoms, which will be in your 40s. So how that will pan out, it remains to be seen as to how. And the CMS is, playing. They're being cautious about approving it for widespread general use. Okay, the other thing that maybe come to the mind is medical devices. That again, so that's another thing that I've learned type of thing as to how, it's a big market of $176 billion in 2020. As many as 30 million US citizens have one type of device, whether it be joint or this thing. And now this was enlightening to me as to how the devices are approved, whether it's FDA cleared or approved. The cleared means it's just similar to what it was there before in the last generation. It does not have to be tested in human, even in animal trials. Okay, so that's one way to bypass a lot of testing. So it's just FDA cleared. So it's similar type of thing. So it's just like buying a car. Oh, it's similar to another car. But it does not mean it has gone through rigorous testing. And a lot of times patients find out the hard way through either social media or when they see ads like this. Okay, have you had complications? So this is, this is how sometimes people find out. Okay, and unfortunately, all these joints they're not allowed to import from anywhere else. So only 1 or 2 companies have a huge stronghold on hip and joint replacements. Okay, and there was a smaller company called DePuy that was a joint manufacturer. Now that is part of the big giant Johnson and Johnson, and they marketed a hip joint which they revised, that instead of the a different type of coating, they change it, so it was metal on metal, that type of joint, and it was considered the new approved. It was not tested out in trials or even in animal this thing, and it was marketed to orthopedic surgeons. And when finally people started getting problems, they heard a big plop type of thing, and there was either, and when the surgeons aspirated the joint, they were able to aspirate a cheesy, colored type of material, and because the chromium metal that was used, was breaking loose, and some people were getting chromium toxicity, and obviously that caused a lot of class action suits type of thing, and the companies, they have paid out almost $3 billion of worth of claims. Okay, and this was promoted heavily by the pharmaceuticals, so much so that the salesman had a big party, when this big costume party, including the talk by the MD who designed the particular metal on metal joint, and obviously, he was handsomely rewarded with $20 million in royalty. And again, and so it required a lot of patients went through a lot of anguish and morbidity. At the same time, even some of the devices are easier to remove, some are harder to remove. For example, a lot of times women get prolapse of the uterus and a vaginal mesh tissue was inserted, and then it became part of their internal anatomy. So they almost had a feeling of like a sandpaper inside them. And that again, the data was not easily aware. The patient did not even receive letters for recalls.
Kevin raised his hand.
I'm sorry, go ahead, please. Yeah.
Kevin,
Yeah, just a comment about clearances and approvals. I've had a pretty good experience in that.
Oh, absolutely. Yeah. Oh, absolutely.
Clearances are for, as you said, for similar devices that are already on the market. And it takes about 1 person year to fill out the application for that. And then you are subject to an FDA inspection in person. So it really takes about a year to a year and a half to get a clearance on what they call a 510K process. For what they call investigational new devices, those require clinical trials, usually animal trials first and then human trials. Those days, depending on the drug, those can cost anywhere, or the device, anywhere from 5 million if it's a trivial device up to over $100 million. So it's a pretty involved process, and I have to say it's pretty rigorous. They had some well-publicized, the FDA's had some well-publicized missteps, and they made the process much more rigorous over the last generation.
Mm-hmm. Oh, absolutely. I think, because, for example, I have a slide coming up later on for the heart valves, and I went through that, when there was a heart valve, it was called Bjork-Shiley valve. The name is not important, but that valve.
I know the Bjork-Shiley valve well.
Oh, yeah. Yeah. So, that's the fracture. It was, really a difficult listing as to how we used to have to call patients for ultrasound, so it's, and we were just like walking on eggshells, basically. So
they actually had to disinter some patients that had passed away due to that.
Yeah, absolutely. So no, I think it's this thing. So it's like the technology has its, it's like, and these are, I think, somewhere along the line, right? We're dealing with sort of technology which are in between. They are not like perfect, like vaccine. Smallpox vaccine is like one of those perfect this thing that 100% success rate, easy to manufacture, easy to administer, that thing. So these are kind of in between level technologies that we're dealing with, which are, they're good, but not ideal type of thing. So I remember reading somewhere about what type of inventions that we're dealing with. So okay, I think we are coming up to 12 p.m. So and I think we have about, at least on my part, I have about 50 or 60 slides left. So hopefully we should be able to cover this and I think some of that like I can minimize this thing and I'll try to edit out the slides so our Dr. Joel will have time type of thing. So I think I should stop here right now and I'll probably continue next week. I mean, I can go on for a while, but I'm sure people have better things to do than listen to me yakking away. So I will, I'll stop by and